Dr. Makhtar, and I also want to thank my co-chair of the meeting, Dr. Peter Tan, for working tirelessly to put together what I think you'll believe to be an outstanding first and inaugural Anesthesia Patient Safety Symposium. I also want to thank the several organizations from Malaysia that really created this experience for all of you today, as well as the collaborating organizations, the ASA, the Anesthesia Patient Safety Foundation, and the WFSA. So without further ado, I'm going to first talk to you about my disclosures. I'm editor of the Anesthesia Patient Safety Foundation newsletter, the secretary of the APSF. I recently received an APSF grant for this specific topic. I've also received grants from Cook and Merck regarding bioenvironmental contamination and outcomes in cardiac surgical patients using sugammadex. So the objectives of this talk today are to define failure to rescue, identify the prevalence and factors associated with failure to rescue, discuss some of the monitoring capabilities and early warning scores, and then discuss the present and future role of artificial intelligence in reducing failure to rescue, and then make some conclusions based on the next 25 minutes. So there are a variety of definitions out there to define failure to rescue. The most appropriate one for this discussion today is the failure or delay in recognizing and responding to a hospitalized patient experiencing complications from a disease process or medical intervention. And in my extensive review of the literature, the overall rate of failure to rescue is at least 12% of the operations in the United States. So it's a very common phenomenon. So common that failure to rescue is now a surgical quality indicator in the United States. And there are really three primary reasons why it's a surgical quality indicator. First, we know that postoperative complications do occur despite appropriate care from our providers. Number two, we know that hospital characteristics that I'll go into later are associated with failure to rescue, and therefore they can be measurable. And number three, we know that early and appropriate treatments and therapies can improve outcomes associated with failure to rescue, also a measurable endpoint and outcome. Now, Dr. Domino is probably going to go into more of our data on anesthesia closed claims, but I want to point out the comparison over a 10-year period of time of those patients who had permanent death or disability, comparing all outcomes versus failure to rescue. And there are some commonalities in the closed claim database. First of all, patients with failure to rescue had a higher ASA score of 3 or greater, and they were commonly orthopedic patients. Also, the more common events were opioid-induced respiratory depression, which we'll go into later, cardiovascular and respiratory depression, postoperative hemorrhage, and spinal epidural hematoma. When we look at the Anesthesia Incident Reporting System database, there's over 1,700 reports of failure to rescue, and 63% of those were deemed to be completely preventable. Some of the reasons for failure to rescue include lack of recognition, lack of the definitive diagnosis, lack of appropriate and early monitoring, and the delay in escalating care. So a real problem in the perioperative world today for all of us. Now, the Anesthesia Patient Safety Foundation made clinical deterioration one of its top 10 perioperative patient safety priorities. And Dr. Cole earlier tonight talked about these priorities, but I want to spend a little time talking about how we developed these. This was developed by about 18 multidisciplinary, multi-professional providers on our board of directors. And what we did is we used a modified Delphi technique to compare one patient safety priority versus the next. And these floated to the top 10. And again, clinical deterioration is the third on the list. Well, there are several factors that are associated with failure to rescue. At the top of the list is age. And we know that greater than 80% of all postoperative mortality is associated with patients who are greater than or equal to 65 years old. In fact, in one study, in high-risk pancreatic surgery, there was a 2-time increased risk in patients who were greater than 65 or older to develop postoperative failure to rescue versus those that were less than 65 years old. In addition, race may play a role in failure to rescue. In fact, a recent article in the Journal of Surgery suggested that those patients who were African American had a significantly higher rate of failure to rescue versus those that were Caucasian. In addition, frailty also is related to failure to rescue. When we talk about frailty, we talk about physical performance, gait, speed, nutrition, mobility, cognition, and mental health. This has been clearly associated with a higher risk of failure to rescue. In addition, patient comorbidities such as chronic renal insufficiency, chronic obstructive pulmonary disease, and coagulopathies can also increase the rate of failure to rescue. The complexity and invasiveness of surgery, such as pancreatic surgery, esophagectomies, as well as aortic surgery, have an increased rate of failure to rescue. And finally, and I think most importantly, is hospital characteristics. And it's been shown in the literature that low-volume surgical hospitals are associated with up to a 45% increased rate of failure to rescue versus and when compared to high surgical volume hospitals. So volume actually does matter. So this we call the pathophysiologic spectrum. And on the left side of your screen, we have stable patients postoperatively who end up with great outcomes and leave the hospital. And on the very right side extreme, we have patients who develop organ failure after surgery and ultimately potentially death. Well, what we need to do is we need to find that sweet spot where patients are transitioning from the stable condition to a compromised condition, and then we can earlier intervene and afford these patients still a good outcome. So the question is, how can we do this? Well, first of all, we have to recognize that delayed care increases morbidity and mortality. And there have been several articles in the last 20 years with regards to this fact. This is one article. It's a retrospective data review of the MERIT trial looking at rapid responses. There's 23 hospitals, 700,000 hospitalizations, 3,000 rapid response activations were analyzed to compare timely versus delayed response. And delay was defined as greater than 15 minutes to the bedside. What did they find? They found that for every 100 delayed calls, there were 13 potentially avoidable deaths. Clearly, it shows that when you don't have a delay, you have an improved patient outcome and survival. So early recognition matters. So how can we more earlier recognize patients who are deteriorating so we can avoid that failure to rescue endpoint? Well, it starts with the bedside monitoring of providers. And this was an article in the New York Times a few years ago during the height of the pandemic, explaining that nursing is in crisis. Staffing shortages put patients at risk. And I quote, "When hospitals are understaffed, people die." And we've known this for the last 20 years. In major medical journals throughout the world, we know that hospital nursing staffing and low staffing to patient ratios increases patient mortality, nursing burnout, and job dissatisfaction. And the right of the screen, you'll see that when hospitals invest, such as the magnet hospitals, into nursing leadership, quality and patient safety, and making sure that the nurses are actually credentialed for their work appropriately, there's an improvement in morbidity and mortality. In addition, we have to break the feudal cycle. And I call this the culture of failure. And I think we've all been here before. And that is when maybe a junior nurse sees an abnormality at the bedside and has to bump it up to a senior level nurse who bumps it up to the junior doctor and then bumps that up to a senior doctor. And by the time a decision is made, there's an adverse event that occurs. We have to break through this vicious cycle. One of the ways that we might be able to do this is the invention and institution of early warning systems, where there's an identification limb or afferent limb using vital signs, physical exam findings, laboratory values, as well as neurologic status. And then that triggers a response or afferent limb, which increases monitoring, clinical escalation, provider notification, and even output of rapid response teams. Well, this was one successful story of early warning systems. The Kaiser Permanente hospital system of 21 hospitals in Northern California instituted an advanced alert monitoring activation and response system. They developed their own electronic health record high-risk scoring system based on their own hospital patient database. And when a patient hit a specific high level of potential for clinical deterioration, they actually had a virtual nurse review the patient's chart. And if that patient met the criteria for clinical deterioration, that clinical virtual nurse would reach out to the bedside local rapid response teams, which would then deploy to the bedside to actually diagnose, monitor, and intervene if the patient needed to do so. So what they found over the first year of implementation was that there was a 4% absolute mortality reduction. They also found that they prevented 500 deaths when they instituted the system. So a huge success, such a success that it actually won the John Eisenberg Award for Innovation in Patient Safety and Quality in 2021. Well, you might ask yourselves, do early warning systems, are they really ready for prime time? Well, we published this article by Dr. Winters, who's an expert at Hopkins, in an APSF newsletter entitled Early Warning Systems Found Dead in Bed Should Be a Never Event. And what he did is he performed a systematic review of all the early warning scores out there. We actually at our institute use the ECARD score. But if you look on the right side of your screen, you see that the effect on the incidence of cardiac arrest and mortality were either not studied or weren't significantly changed. So you might ask yourself, well, why don't we see a significant benefit? Well, it really has to be predicated on three variables: appropriate data, prediction models, as well as an alert response. And when we talk about data, we need to make sure that the data is physiologic, continuously monitored through a specific record, and that we can query it on a real-time basis. We also need to make sure that the models are clinically relevant, that they have a high sensitivity and specificity, and again, they can be performed in real time. But we also have to make sure that the alarms and the fatigue is manageable, that we appropriately train providers on how to intervene appropriately and early on in the disease process, and that we target the appropriate responders to intervene. So there are a lot of unanswered questions with regards to early warning systems. Who should respond? How should they respond? Do they reliably increase sensitivity and specificity to clinically meaningful events? And can they improve patient outcomes by reducing rare adverse events? So the Anesthesia Patient Safety Foundation developed its 2019 annual Stolting Conference entitled Perioperative Deterioration, Early Recognition, Rapid Intervention, and the End of Failure to Rescue. And in that conference, about 120 multidisciplinary, multi-professional providers attended, and we were all broken up into small groups to develop 19 prototypes in the following domains: technology, culture recognition, training, and system workflow. And of those 19 prototypes, the APSF awarded 3 grants to develop these prototypes. And I'm proud to say that our group was one of those 3 grants awarded. So what we did is we tested a proof of concept model for real-time dual interactive decision support in the perioperative period using audiovisual cues during 3 simulation scenarios: anaphylaxis, amniotic fluid embolism, and a pediatric dental case involving laryngospasm. We used 20 anesthesia professionals and randomized them to the standard of care group versus the audiovisual decision support group. We looked at time to appropriate diagnosis and time to appropriate interventions. And I'm going to share with you today a practice evaluation of one of the audiovisual decision support tool scenarios. This is the pediatric case that went into laryngospasm. Go back here.
This is a laryngospasm/bronchospasm. So what I'm doing is I'm securing the airway. I have end-tidal CO2 now, but now my heart rate is going down. Yes, please provide.
So I have an audiovisual tool in my ear that, based on the physiologic abnormal vital signs, is providing me a differential diagnosis that will then allow me to have an emergency manual prompted up on the screen above so that I can follow the appropriate interventions in a timely fashion.
So I'm going to go ahead and give that now.
So what we found in this study, most significantly, was within the pediatric dental case, we found a reduction in time to diagnosis and a reduction in the correct diagnosis before the second vital sign change in this specific case in the interventional group versus the control. So now we're repeating this study in a trainee model among anesthesia residents as well as SRNAs, and we are trying to look at AI technology and trying to integrate it with the hardware of a Google Glass lens that can be potentially used in the perioperative period. Now, what is the role of artificial intelligence in patient safety outcomes? Well, this is a systematic literature review of all those specific articles. And most of the articles were looking at drug safety, clinical incident reports, as well as error alerts and false alarms. And some of the conclusions of this article were that we really don't have a benchmark standard to compare some of the AI reports, and there's a lot of heterogeneity within the specific studies. We also, as the APSF newsletter, produced this article, The Pro-Con Debate, with Dr. Buse and Mather, entitled Artificial Intelligence in Healthcare. It Might Not Be a Magic Pill. And some of the solutions for effective deployment of AI in healthcare should be that it should be patient and care provider-centric, that clinicians should lead the development and implementation of AI at the bedside. And there has to be rigorous model development and testing. The algorithms have to be explainable and interpretable, and they have to be scalable to the larger population. And of course, they have to be cost effective. And so there are several barriers, whether in terms of adopting AI at the bedside. And then you put these in really into 4 buckets. Reason to use, meaning is there alignment? Are there incentives to adopt AI at the bedside for failure to rescue? The means to use, do you have the infrastructure? Do you have the financial, human resources to invest in an AI technology? And then the workflow and efficiency. Can it improve what we do at the bedside? And can it work within our workflow? And then 4, desire to use. Do we trust what we're doing and what information we are being given by the AI technology? So one of the areas of adverse events that AI could be employed is opioid-induced ventilatory impairment. And the APSF newsletter really designated the 2018-19 issues to this very adverse event that we've been tackling for the last several decades. The Anesthesia Patient Safety Foundation recommends that there should be continuous pulse oximetry in patients who are receiving opioids, not on supplemental oxygen, while in addition, monitors of gas exchange should be used in patients with oxygen. We all know that opioids reduce the ability to enhance respiratory drive and reduce ventilation, and can cause hypercapnia and eventually apnea and respiratory failure. Well, this was a study we published in the APSF newsletter by Lee and Domino and colleagues looking at the closed claims database with this unwanted event. And they found that 66% of the patients were obese, but 63% of them were ASA 1 or 2 healthy patients. So this can happen to anybody. And then they also looked at where is this happening? Well, it's happening within 24 hours after surgery in 88% of the cases that they reviewed. And 13% of the cases occurred within 2 hours of arrival on the floor from the PACU, suggesting an area that we can focus regarding increasing monitoring and increasing bedside resources. We also published these articles in the newsletter requiring monitoring for opioid-induced respiratory depression, prescription drug monitoring programs, as well as the institution of multimodal analgesia and alternatives to reduce the use of the opioids in general. We translated this in 5 different languages for our international constituency to make sure that they understand and that they can gain global knowledge of how to counteract this adverse event at the bedside. One article that we published about 10 years ago looked at the institution of continuous pulse oximetry in an orthopedic unit postoperatively in patients who were receiving opioids. And what they found was that there was a 60% reduction in rapid response team calling and a 50% reduction in ICU transfers. And they deemed this a cost-effective system for the hospital in general. In addition, the APSF newsletter published this article with regards to the Candor Health System instituting both continuous pulse oximetry and capnography at the bedside in patients who had continuous PCA or PCA being used. And they instituted this algorithm, and with this algorithm, they afforded a significant reduction in adverse events related to the PCA or PCEA. They found that over 5 years, the return on investment was $2.5 million, accounting for this reduction in adverse events. So not only is this worthwhile for our patients, but it also can be cost-effective for hospital systems. This is an article looking at building a risk factor score for respiratory depression. It was an international study looking at 16 sites in Europe, US, and Asia, over 1,200 patients, to really look at how common respiratory depression is in patients getting opioids and general hospital floors. What they found was 46% of the patients had one or greater respiratory depression episodes. They used this patient population to develop the risk scoring system, looking at age, sex, history of opioid use, sleep disordered breathing, and chronic heart failure. And of course, the higher risk score you have, the more correlation there is to respiratory depression. And this was a follow-up study looking at patients in the PACU using the Prodigy score. And you can see on the right side of the screen, those with a high Prodigy score had a 17% incidence of respiratory depression. In addition, Sessler and colleagues wrote this editorial regarding beyond failure to rescue. Enhancing the time has come for continuous ward monitoring. What he's recommending is in developing artificial intelligence to identify patients currently at risk so that we can monitor a vast amount of patients and intervene much earlier than we do now. In addition, we now have wearables, ingestibles, and even implantables that can actually look at monitoring blood pressure, heart rate, electrocardiogram, and even oxygen saturation. And as Dr. Cole remarked earlier, we can use this data even as an outpatient to actually try to identify patients that might be deteriorating so that we can get them back to the hospital or care centers to treat them appropriately and effectively. Now, this is a systematic review of all the artificial intelligence intervention literature as it applies to opioid use disorders. And I just wanted to remark what's out there. Well, there's 20 unique interventions, 29. Smart phone applications, healthcare data-related interventions, biosensor-related interventions, digital and virtual-related interventions. And the conclusion of this study is really that we need more research which examines the usability, utility, and acceptability of artificial intelligence interventions. So in conclusion today, failure to rescue remains a patient safety initiative and a surgical quality indicator. Postoperative events, adverse events are underestimated, but we know that early detection reduces the need for rescue. Questions still remain as to the most effective way to enhance the efficacy of the afferent and efferent limbs. But I think we need to incorporate the three rights: the right professionals at the bedside, the right timing, and appropriately instituting the right therapies. Thank you so much, and I'm looking forward to your questions and hope you have a great rest of your conference.